Hello, and welcome to episode 1 of our 4-part series called Nothing to Fear, Meaningful Conversations About Life and Death. This series is in celebration of Hospice of Northwest Ohio's 40th anniversary. My name is Sarah, and I've been a nurse for 12 and a half years, most of which has been at the bedside between the intensive care unit and for the last 5 years with Hospice of Northwest Ohio. I have been talking about and physically in the same space as death professionally and personally for the last 10 plus years. And let me tell you what, being able to acknowledge your own mortality really can help make you live. When I left the bedside, which was directly caring for patients day in and day out, my biggest goal was to show people that talking about death doesn't have to be all morbid and depressing. Of course, it's going to be sad to think about, but it can also be surprisingly meaningful and beneficial in ways that you never would have considered before. Today is our first episode, and we are focusing on a few members of our interdisciplinary team, who I'd like to introduce you to now. First, we have Laura Conant.
Hello, everybody. I'm Laura Conant. I am a licensed independent social worker, and I'm originally from Kentucky, where I spent several years working in mental health, substance abuse, and foster care. I really didn't know what hospice was until my husband's stepfather actually needed hospice services, and I was just incredibly moved and surprised really by the care that he and my mother-in-law received from this hospice. It was down outside of Columbus, but it wasn't long after that I sort of just started feeling the call, and I've been lucky enough to be at Hospice of Northwest Ohio now for 15 years. This is my 15th year.
That's awesome. Thanks, Laura. Next is Sakina McNeil.
Hi, I'm Sakina McNeil. I'm an STNA with Hospice. I've been with Hospice this year, make 12 years. I didn't know much about Hospice. I worked at a facility here in the Toledo-area, and I saw the nurses and the aides that used to come out to our facility and help care for our patients, and I love the work and the care that they provided for our patients, and that's what interests me in hospice.
Thank you, Sakina. Now it is my pleasure to introduce Sherry Holdridge.
Forgot to unmute. Good afternoon, everyone. I have been an ordained minister for about 30 years, and I started working as a hospice chaplain about 4 years ago. I did some special training in a hospital called Clinical Pastoral Education to train me to be a chaplain. And I've been with Hospice in Northwest Ohio for about a year and a half, and I absolutely love being a chaplain. I appreciate the privilege of walking through this journey with our patients and their families, and it's great to be with you all this afternoon.
Thank you, Sherry. And last but never ever least, Maren Simon.
Hi, everyone. Like Sarah said, my name is Maren Simon. I am a licensed social worker in the state of Ohio, and my role at hospice is that of a bereavement counselor. I have a background in gerontology, always knew I wanted to work with older adults, and ultimately was led into hospice care due to personal experience with hospice and the care of my grandmother years ago. Not here in Ohio, but have really found myself connected with Hospice of Northwest Ohio and my wonderful colleagues. And I've been working as a bereavement counselor for just about 2 years.
Wonderful. So the first thing that I want to talk about is total pain, which is sort of the basis of the hospice philosophy. The founder of the hospice movement, Dame Cicely Saunders, recognized the challenges associated with receiving a terminal diagnosis. But more importantly, she recognized that those challenges were very unique and they should be treated as such. Everyone who is dying is going through it for the first time, because if they weren't, they wouldn't be here. There isn't one discipline, like a nurse, for instance, who can effectively assess and treat all of the aspects of what she called total pain. This is why her approach involved disciplines working together: a physician, a nurse, an aide, a social worker, a chaplain, volunteers, and bereavement counselors, and not to mention all of the dedicated administration and office staff. So each of these ladies are going to tell us a little bit about their role in the interdisciplinary team. I want to start with Laura because I think as a nurse that social workers are one of the most generally misunderstood disciplines. And I told Laura this yesterday. I was often one of the first permanent team members caring for a patient that I would meet. And when I would mention that a social worker was on our team or available, it seemed like people would almost immediately jump to, oh, I don't need a social worker, as if that meant there was something wrong. So Laura, why don't you describe what it is that you do?
Sure. Thanks, Sarah. And I think Sarah's right. Outside of hospice, people have experiences with social workers that are very different, and they a lot of times have a preconceived notion of what we do. But as a hospice social worker, we do a lot. We wear a lot of different hats. People on hospice are going to have all sorts of different needs. They come from all different backgrounds, different ages. Some people have very specific needs, like help with advanced directives or choosing a funeral home. Other people might need help actually getting enough food in the home or helping pay for their utilities. People sometimes have strained relationships that they would like to repair, or maybe some caregiving needs that aren't being met. Social workers are there to help with all of these kind of issues for our patients and families. But with all these different issues that there's usually one thing that everybody has in common, and one reason why really everybody could use a social worker. Sarah, as you mentioned earlier, we've never been through this. When we come to the point of dying or losing someone who we love, it's a situation we haven't been in before, so we don't really know how to do that. And I would say at least 95% of the people that I talk to have some emotional pain or some psychological pain that's sort of wrapped up around that, which is a piece of that total pain that you were talking about. And so a big part of what I do as a social worker is just sort of help people figure out what they are feeling and maybe where to go with those feelings, whether they are sad or angry or maybe even relieved on some level. There's no wrong feeling, and it's really important for me as a social worker to help people sort of understand that there's no wrong feeling. And one of the best things about my role that I always like to highlight is that when I come into a situation, I don't know you. I don't know your history. I don't have a history with you. So I can be present to our patients and our families in a way that their families and friends can't be, because they do have that history and that relationship. So people can be fully open and present with me without fearing that I'll have any judgment or think twice about it. So we do a lot, hospice social workers.
You guys are truly, the saying is jack of all trades, master of none, but you guys are jacks of all trades, masters of a lot as well. I love that you said there's no wrong feeling. And we have talked before about going into a home with absolutely no preconceived judgment. So thank you for making that point. So next we'll be talking to our hospice aide, Sakina. What kind of things are you doing on a daily basis?
The things that I do on a daily basis, I provide patients with baths that need help assistance with dressing, bathing, sometimes making a meal, or sometimes just being that shoulder to cry on or someone to talk to. I love what I do. I'm sorry here. I'm trying to.
I gotta jump in here and say that I feel like our hospice aides, and definitely Sakina being one of them, are the best. They are the ones seeing our patients most frequently. And when she says a shoulder to cry on, I think that is absolutely true. I mean, our patients and families, they come to rely on Sakina and her coworkers as much or more as any of us.
Yep, and we're also the eyes and ears for everyone on the hospice disciplinary team. We see the patients probably the most throughout the week than anyone else does. So we observe and any concerns that a patient or their family may have. We contact the nurse or social worker or whoever is in charge, and we go from there. And our patients just, we try to make them feel better. It's something as simple as a bath, or just as simple as a walk a walk down the street, walk in the park, whatever that it is that they may need. Even the family, sometimes we're just there to just relieve them of things, of their duties, or just so they can get out and have, get a break or whatever it is that they may need to do.
Yes, thank you, Sakina. And Laura, I agree with you. One of the things that's the best about our aides is they take a situation that can sometimes be a very intimate, very personal, needs situation, and they all somehow make people feel comfortable very quickly. And that to me is just such a gift. And Sakina's right. They see the patients probably more frequently than most other disciplines, I would say. So yes, thank you, Sakina. Next up is our chaplain, Sherry.
So one of the things that impressed me when I started working for hospice was to learn that every hospice has to offer spiritual care to every patient. The patient doesn't have to take it if they don't want it, but we call every new patient. One of the chaplains calls and offers to go out and meet them in their home. We try to visit every patient at least once to assess their spiritual needs. And even though I may be Christian, which I am, I meet the patient where they are spiritually and try to support them. And so the first thing I do is try to assess their spiritual pain, whether or not they're having relationship pain or perhaps a loss of meaning in their life, they're having questions, or maybe they're fearful about end-of-life issues. And I'm there not only for the patient, but for their caregivers, whether it be family or other caregivers who have come into the picture. So I can offer services both to the patient and their caregivers. And I go out, my particular team focuses mostly on people who are living in private homes and a few people who are in facilities. So I go to them where they are in their homes, visit them usually once or twice a month, and visit maybe 30, 45 minutes, an hour, and give them support. I let them kind of take the lead and talk to them. Sometimes if they have a Christian background, I'll play them some old hymns and they'll sing along with me. If they're Protestant, I can take them communion, or I just listen. If they're not very verbal, sometimes I just sit with them and play music, and I'm just a calming presence with them, just to do whatever I can to support them on their journey. And sometimes we just chat. We don't talk about serious religious things. We just talk to provide some companionship. A lot of the patients are suffering from a sense of isolation because they can't get out. And so it's just helpful to have a friendly visitor. So that's some of the things that I do as the chaplain.
Thank you, Sherry. I loved going on visits with chaplains. It was always such a very peaceful presence and visit. And then so last we'll have Marion, our bereavement counselor, speak to us a little bit about kind of her day-to-day assessing and treating with patients.
Yeah, so in bereavement, the majority of what I do is working with individuals and families after they've experienced a loss, though sometimes getting involved before that as support to the others you've already heard from, in anticipation for that loss, and how we can best prepare, although there's truly no way to know how anyone will respond after the fact. On a daily basis, in bereavement, we do mostly one of two things. The first being individual counseling, so one-on-one support with folks a lot of people really benefit from just having somebody to talk to. Like Sherry was talking about isolation, grief can be very isolating. It's hard to feel the freedom to share and express the variety of feelings and responses someone can have to grief. We don't talk about it much at least in our society here. And then the second is support groups. So I have the privilege of facilitating one of our spousal partner loss support groups, but we have a variety of different types. And perhaps most special to Hospice of Northwest Ohio is all of our bereavement services are provided to anyone in the community, whether or not you've had experience with hospice or not, whether or not your loss was related to hospice. So it's free of charge, and we work with a variety of people coming from a variety of backgrounds. And I really love what I do.
That always shines through you as well, Maren. I will say on a personal level, my first touch with Hospice of Northwest Ohio was a bereavement counselor. And since then, I've been also very loyal to this organization. So thank you, Maren. So as the home care nurse, I would actually be in charge of visiting the patient and their loved ones' caregivers at least once a week and talking about the physical symptoms. I saw one of my most important roles was education, to talk to them about what to expect as the disease progression continues, what things are normal, and this often prepared them instead of shocking them. And then I would also reach out to these other disciplines and these colleagues if I felt that there were certainly aspects of total pain that were beyond my reach, which is why Dame Cicely Saunders created this model that way. So for the people who are watching, we are happy to take questions, but I am going to ask my first question to the group. And I like asking this question in front of groups to our employees because it's usually a pretty good reaction. But my first question for all of you is, what are the reactions that you get from people when they learn that you work for Hospice of Northwest Ohio? We're going to start this time with Maren.
Yeah, so there are a variety of responses that I get. I think the most common is, gosh, that has to be so difficult. How do you do that every day? I think the one that I specifically get, usually if I say I'm a bereavement counselor, is I end up hearing people's story about a loss that they've had, whether it was with Hospice of Northwest Ohio or on hospice at all. And I consider it a big privilege. I don't think people have that opportunity often. So I think the second they hear, oh, I work for hospice or I'm a bereavement counselor, the door opens. And yeah, it's a privilege to listen to that.
Absolutely. It's such a sacred space and people are very open and sometimes vulnerable, during that time. What about you, Sakina? What reactions do people give you when you tell them you work for hospice?
I get, you guys are angels. I get, oh, that must be a hard job. You must be a strong person to work a job like that. And I get people that just come up to me. If I go in the store and I have on my name tag or something, they'll just come up to me and give me a hug and tell me how much hospice has done for them if they had a loved one on the program, and how they appreciated everything that we've done and all the care that we provided.
I love that you said that about the grocery store, because that's happened to me too before. And what other professions or careers can you say that about? That a perfect stranger will hug you because of your name tag. So thank you. And then Sherry, what about you when you tell people that you work for hospice?
I also get the response of, oh, that must be so depressing, and I could never do that. My two children, even, who were both teenagers when I started doing this work, thought it was a terrible idea and thought it would be so depressing for me. And in fact, after I had been at a hospice in Northwest Ohio for only a few months, my own mother became a hospice patient. And the last few weeks of her life, we brought her to our house to die. It was during COVID. She didn't have COVID, but we brought her to our house so that we could care for her. And my daughter was home from college because of COVID and was able to help care for my mother in her last few weeks of life. And it was a life-changing experience for my daughter. And my son, who still pretty much thinks it's weird that I do this, finally got to see kind of what I do in seeing me interact with my mom. And he interacted with her when she had some of that dementia that we sometimes call pleasantly confused, and had a few laughs with his grandmother. And I think he finally got a glimpse of what a privilege it is to walk with people at the sacred time. So people just, they haven't experienced what it is before. So I think they're just afraid of what they don't know.
Yeah, I couldn't agree more. So I didn't see any questions pop up, so I have plenty for you guys. So I'm just going to keep rolling here. And on that note, that people are kind of afraid of what they don't know, that also goes along the line of misinformation. And that is, thank you very much to Debbie and Steve. We all know that misinformation is a giant problem and kind of a hot topic right now. And hearsay about hospice programs like Hospice of Northwest Ohio is included in that misinformation. I feel like at this point, as a community educator, pre-COVID, when I was going out to libraries and senior centers, I would often ask, what things do you hear about hospice? And I have heard it all. So we're going to sort of take turns raising our hands to say some of our myths that we hear the most often, or that we've heard that have sort of blown our minds. And I'll start. The first one that really blew my mind was at a library, and somebody raised their hand and said, I heard when you're on hospice, you can't, they don't let you eat or drink anymore. And I was like, oh, quite the opposite. We actually encourage you to do both of those things, you know, as long as you're able and what you want to eat. So that one kind of blew my mind. Anyone else have one off the top of their head? Let's start with.
This actually just happened yesterday. My own husband, despite knowing a lot about hospice from me, didn't realize that you can receive hospice at home. He thought it was, you had to go somewhere. And I guess he gets confused by like an inpatient facility or a hospital, but didn't realize that you can actually also have it at home.
Yeah, that's a great one. That's a very common one, I think, is that hospice is just a place you go. Anyone else raise your hand? Laura?
I have a family story too, but the myth that I have encountered many times is that morphine kills people, and that we use morphine in order to, you know, help things along. And this was several years ago, I talked to my aunt, and we got into a conversation about hospice, and she shared with me that she had for 30 years believed that she killed my grandmother because she was giving her what the doctor ordered. And 30 years she carried this pain and this shame. And I was so grateful that she shared it so that I could help her understand that, you know, my grandmother had cancer. She had a lot of cancer, and the morphine was helping, not hurting. So I think I've heard that from a lot of patients and families over the years, unfortunately.
Yeah, that is definitely one that as a nurse, I was doing a lot of education on, especially with older folks who were very afraid of just the word morphine or any narcotic, for instance. The thing is, morphine is, when used in small doses under the direction of a physician for legitimate pain, that's what it is. It's a painkiller, and it blocks pain signals to the brain. So that's the mechanism. And I always told patients, the people who misuse these drugs, who don't have true pain signals, who are using this not for pain, are the ones who get those reactions that they're worried about, or the feeling of being high, if you will, using it recreationally. But, you know, you could say that about Tylenol. When I was working in the ICUs, I had 3 patients who tried to, kill themselves off of using too much Tylenol. You can say that about alcohol. You can say that about, water. There are hazing incidents in fraternities where if you drink too much water, you can decrease your sodium level so much that it affects your heart. So yeah, morphine, using morphine to hasten death is not something that hospice does. And you're right, Laura, I'm glad you brought that up, because that is a very common myth, not only among the community, but even among some of our own patients. And as the nurse, we try to talk about that early on. So if it comes up, or even sometimes when it comes up for pain or shortness of breath, we've already started that conversation.
Right.
How about another myth? Anyone else have one? Sherry.
Well, before I started working at hospice, I thought it was expensive. I thought people had to pay for it, and I didn't realize that for almost everyone, it's paid for either through their Medicare benefit or through their private insurance. So that was a big one for me.
That's another one that I've heard a lot in the community too. How much does it cost? And talking about how Medicare pays for it and Medicaid. It's just kind of a section of your insurance opting hospice. So yeah, another big one that I've heard is that you need a physician referral, which is not true. Sometimes we have a family whose mom we took care of, and then they call a couple years later and said, we think it's time for dad. You do not need a specific physician referral to come on a hospice program. So if we could bring up the slides, the two most important ones, I think, of the myths that I have come across, the first one being that hospice is a place that people go to receive care. And that's sort of what Laura was talking about as well, or I'm sorry, Marion was talking about as well. And there are certainly different levels, but really hospice is a philosophy of care. And it's that idea, that concept of total pain. So hospice, the truth behind this myth is that hospice is a philosophy of care. The different levels as far as physical place would be the inpatient unit, and that is for acute symptom management. So somebody who has uncontrolled symptoms in the home and needs to come in for an average of 3 to 5 days to get those symptoms under control and then go back to wherever they call home, their comfortable environment. So we do the home care, we do care in extended care facilities, and we also have our 2 inpatient units. And then back to Medicare and Medicaid, that myth, we also will provide care, being a non-for-profit local community agency. We provide care to people who don't have insurance as well. But the next slide, the next myth that I find to be one of the more common and important ones would be that hospice hastens death, or it won't treat anything, or takes people's medications away. And the truth to that is that hospice does not utilize any interventions in order to hasten death, but we also don't artificially prolong life with things like a breathing tube, life support. So we use individualized care plans to meet patients' specific goals, and that includes medications such as morphine or anti-anxiety medications, different types of therapies that are goal-driven, and even preventative and interdisciplinary interventions like we've been talking about today. Some of the preventative therapies that sometimes people are surprised to hear is that we give our patients flu shots. So I've taken flu shots to the home to give patients. There are times we'll do physical therapy, occupational therapy, or give blood. It just depends on the situation, the goal of that intervention, and the goals of the patient and where they're at in their journey. So I'm going to see if there's any other. Let's see. We do have a question from Kathy. Thank you, Kathy. How do you encourage families to call hospice sooner? That's a great question. Does anyone have something off the top of their head from the group? How do we encourage families to call hospice sooner? One of my answers to that would just be continuing to offer educational opportunities about what it is we do, and trying to make it understood that we are not just for the last hours or days or weeks of life. We've had patients on our programs for months to years before they die. So I think trying to battle misinformation and trying to continue educate, which of course I'm passionate about as a community educator, is one of my ways to encourage. but I will open it up to the group. Anyone else?
I think I generally start by asking some questions about what's going on with people and try to engage them in a conversation about, like you said earlier, what their goals of care are. Sometimes people don't realize they're ready for hospice, and the word hospice can be very, very scary. So sometimes I just really get into a conversation about what is going on and what is it that you want at this point. And then sometimes you can sort of back into hospice. And I do just want to say hello to Deb Duchelle, and I saw your comment, and I miss you. We all miss you.
All right. So my next question for you guys, and this is one that I feel like we have talked about, all of us, for. Oh, here's a question from Jenny. Hi, Jenny. If you could change one thing about the care we provide at hospice, what would that be? Oh, Jenny, you and your questions, that was a good one. Does anything come up for you guys? If we could
Music
change
therapy
one.
was really great. I enjoyed it when we had music therapy.
Oh, music therapy, yes.
Yeah. Which we still do a little bit with the volunteers, but it's not quite the same.
There are times that I wish, I know in the beginning of hospice, and I'm talking 40 years ago, we as nurses spent more time in the home as far as like the number of hours we were in the home, especially towards the very end of life. And the way that we're reimbursed and things like that, it can't work that way anymore. But that would be one thing I think maybe that I would change. Anyone else? Good question though, Jenny. Let's see. So my next question for the group, and this one is one that, like I started to say, we've all talked about in our group meetings or our team meetings, but how has working for Hospice of Northwest Ohio affected you personally? And we'll start with Sakina.
Working for hospice affected me personally. It made me prepare for my own personal hospice experience with my grandmother. I was able to listen to the patient and fulfill her needs, but I was familiar with the dying process, so I knew when it was closed. I was able to inform my family members, and I was also able to care for her personally, bathe her, feed her. So it helped me prepare for that.
And that's huge. That's huge. Thank you for sharing that. Next, we'll go to Laura.
It's affected me pretty profoundly in a lot of ways. But I think what Sakina just said reminds me of one of the biggest ways is that it's really helped me to be really open to where people are and not assume that I know where they are. And I was able to benefit from that as well on a personal level with a family member. But just to ask questions without having the answer already in my head, which I think we do a lot. I've really learned through hospice care that I do not know how I would handle anybody else's situation, even no matter how badly I want to think I know what I would do in that situation. I don't. So just really, it's really opened my eyes to the need to just be very present to where people actually are and not where I think they should be.
I know you hate that word should.
I really do.
I know you do. I love that though. I agree with you. I feel like I have learned what a small problem is and what a big problem is. And not to judge people based on whatever problem they're dealing with, because we all have something, right? Oh, thank you, Jenny. Next would be Marin. How has working for Hospice of Northwest Ohio affected you?
Yeah, so it has affected me immensely. I think more than anything, I am so aware on a daily basis. I think more than I would be if I didn't work at hospice, how fragile and beautiful life is. Um, and it's kind of led me to this perspective on life of I want to be present and I want to be in the moment, because it's so temporary. This day is temporary, this moment is temporary, and I don't want to miss it. And I've just really learned to cherish that in my relationships, my family, my friends, my life, and really kind of brings your mortality into perspective. And I think specifically within grief support too, is I have learned so much about love. Like when people are talking about grief, they're really talking about love. And so I feel like I know more now more than ever what it means to actually deeply love other people. Mhm.
As usual, Maren, you like gave me goosebumps. Yes, I love that. I love all of it. And then last but certainly not least, Sherry, how has working for Hospice of Northwest Ohio affected you?
So what I have to say is similar to what others have said, I think, but a little different. I think it's made me a better listener. Lots of times people think as the chaplain, I'm going to come in and like tell something to people or teach them something, but often what I do is listen. And like Laura said, like I don't know how other people grieve or process things. And what I've learned is that everybody processes death differently, and everybody processes their fear and their journey forward differently. And so the best thing I can do is to listen intently and then respond as openly as I can. And one of the things that's great about hospice is that we wrap the families with a care team, an interdisciplinary team. I like to call it a care team with different people on it. And so sometimes the families will pour out their hearts to the chaplain, and sometimes they pour out their hearts to the aide or to their nurse or whomever they connect with the best. And it doesn't matter. Like nobody, we don't have a lot of egos, and we're all just grateful when someone connects to one person or another person on the team and is just able to work through whatever they need to work through. And we just recognize that people are different and connect with different people. And as long as somebody on the team can help them process what they need to process, then that's great.
Yeah, I love that how you said that. And often we say we wrap our loving arms around, as a team, our arms around the patient and the family and the caregivers. It looks like we do have a question from Patty. When a patient is in the hospice facility, so we're talking about a patient who's in the inpatient unit, there is a disagreement with the care between the caregiver and a hospice team member. How is that resolved? For example, the caregiver sees their loved one is restless and wants them to be comforted by medication administration, but the hospice team doesn't agree. Who has the ultimate direction? Ultimately, it is up to the physician, I would say. But in that case, I would think the care team would come together with the loved one who has the concern or that caregiver, whether it's a family member, or a hired caregiver, a spouse, who is bringing up that concern. The patient's nurse, I would say the patient's aide, to get an idea of the mannerisms or what the patient maybe has gone through throughout the day. So the two direct care providers, and talk about the concerns and do a thorough assessment of the patient. Try to figure out, we're always looking at assessing the patient first, what could be causing that symptom, and what are our available options. Ultimately, though, we are trying to provide the peaceful atmosphere that we can in that inpatient unit with the best symptom control. And when those disagreements happen, I think sometimes there's an intervention that is not medication that one of our interdisciplinary members can treat. For instance, somebody who is very restless, who is maybe even still able to converse a bit, maybe they're dealing with a considerable amount of guilt. And no amount of medication is really going to help that type of symptom. And that's where somebody like Sherry or Laura may come in and help with some counseling and talk about the guilt. But I guess without knowing specifics as far as assessment, it's hard to answer that question. But ultimately, it's up to the physician. But our approach is really a team approach, and that team includes the patient, if they can speak for themselves, and of course, the loved ones or the caregivers. Does anyone else have a comment about that question?
Yeah, I just want to agree with what you're just saying. There's always a conversation. I've worked on mostly I work in home care, but I've worked on the unit plenty. And families don't always agree with what is being recommended. And that can be that we are recommending medications. And sometimes the families will say, we feel like our loved one is too sleepy. We want to back off the medications. We may not agree with that, but generally speaking, the physician will honor the family's wishes and back it off and see what happens. And conversely, if the family feels like their loved one is restless or painful, we are going to want to treat that. Sometimes, though, there is conflict within the family, and the caregiver or the family member that's raising this issue may not be the person who's been involved and may not be the person's legally appointed point of contact, their healthcare power of attorney. So sometimes it involves bringing the social worker in to do some family counseling to get at whatever is the root of the conflict or the disagreement in the treatment. But it's always a conversation. I don't think I have ever in 15 years heard a hospice physician say, no, we're doing it this way because I said so. That's just kind of not the way we operate.
Yeah, that's a great point. Ultimately the physician has to write the order for the medication, but it is a team decision. So that was a good question, Patty. So the next question that I have for the group, and this was a question that actually made me a little nervous when I first started working for Hospice of Northwest Ohio, is because even in the ICU, I was dealing with death, but I hadn't really been very well trained in those types of conversations. And I was worried about what would I do when somebody felt a connection with me and started to admit that they were scared. As the nurse, my first question back to them was, I just need to clarify, are you scared of the physical process of dying? Or are we talking about what happens after? Is it the spiritual aspect? So I first wanted to clarify that with them if they opened up to me about this. But Sherry, I'm going to start with you. What do you tell people as a chaplain if they open up to you and tell you that they're fearful?
So that's exactly where I start with them, is I try to determine what they're scared about. And if they're scared about the afterlife, then it's my job to work through it from their faith understanding and help them draw upon their faith to find comfort. And if it's a faith I'm familiar with, then I can help them. And if it's one I'm not familiar with, I can call upon a resource person to come in and help them. Often, when I ask for clarification, people will say to me, no, I'm okay with the afterlife. I think I'm going to go to heaven. I'm good with that. I'm just scared about, is it going to hurt when I die? And I'll say to them, I don't want to put anything on them, so I'll ask their permission. I'll say to them, well, as a chaplain, I've actually sat with quite a few people and been there when they died. Would you like me to describe to you what I've seen? And I said, every death is different. And they're like, yes, would you please? And so I tell them that it's often very peaceful in what I've seen. And they're often very relieved because they just want information. They want reassurance, and I can't promise them anything, but I tell them that our job is to keep them comfortable, and that I reassure them that our nurses and doctors are experts at this. This is why we do this, so that we do a great job at keeping people comfortable. And often they're just fearful of the unknown, and they're grateful to know that they have a team around them who have experience helping them walk through this, and they're relieved once they just have someone give them some information.
Yeah, that's a good point. Giving that information, but I like that you asked permission about that first, because a lot of us have been in the room at that moment of death, and there's something profound about it. But I think before immediately sort of putting that on someone, like you said, asking permission is a great tip there. So how about you, Laura? What do you say to people when they tell you that they're scared?
First, I just have to say how much I love that I got to hear what you would do, Sarah, and then what Sherry would do, and how we're all just a little different. And I feel like we sort of cover all the bases. My tendency is not to ask questions, but to initially just validate what they're telling me they feel. This is scary. Just like we've talked about a couple of times. You've never been through this before. You don't know what to expect. It is scary. And it's okay to be scared. It's 100% acceptable to be scared. I think that a lot of times people are looking for validation. Some of the best advice I've ever received in terms of counseling, whether it was hospice or any kind of counseling, and I try to share it with everybody, is when someone starts crying, don't immediately reach for the tissues. And it's a little bit the same. When someone says they're scared, don't immediately try to convince them there's nothing to be scared about. But if they're crying, let them cry. I mean, if you want them to be able to grieve and experience what they're experiencing, and you want that connection, then just let them cry. As soon as you hand them the tissues, it's done. The moment's passed. And I think it can be that they're saying they're scared. They can be feeling a lot of things. And I, again, just my tendency is to validate those feelings. But I love that we're all approaching it differently, because there is no wrong way. And I think there's an aspect of what you, Sarah, and Sherry are saying, and to what I'm saying in every patient.
Absolutely. Yeah. I love that you brought up almost giving them permission to be scared, and the tissue box debate, which I've talked about before. When I talk about empathetic listening, like, do you reach for the tissues? And some people would say, yes, I immediately reach for the tissues, but it's almost like,
don't do it.
You're stopping them from crying. Right. And it can be uncomfortable to sit in that space with somebody who is crying, or who is grieving, or who is angry, but it takes a certain amount of vulnerability on your end and openness to sit in that space with them and let them feel those feelings. So thank you for bringing that up. How about you, Marion? What do you say if people bring up fear to you?
Yeah, so I mean, to echo what Laura said, I also take a similar approach in validating and normalizing the fear. Like she said, this is scary. I wouldn't expect you to feel otherwise. In addition to that, one thing I try very hard to do is to ask the question of, tell me more about that. Tell me more about the fear. And I try not to prescribe what I think the fear might be of, because especially in folks that are grieving, it could be about a number of things. And sometimes it's something so specific, I would never be able to guess that. And they know themselves better than anyone. So asking the question, tell me more about it, kind of removing a why question, which can kind of insinuate judgment or questioning, why are you scared? But tell me more about the fear.
I love tell me more. That's a great, sometimes when you get caught with something, just a simple tell me more can really bring a lot out. And then you, Sakina, save the best for last, right? What do you do? What do you do when somebody, maybe breaks down and starts to tell you that they're scared?
Kind of like Laura and Marin, I let them know that it's okay, that that's a legit feeling. It's common. I let them get it out if that they want to vent about it. I give them a hug, and I tell them that whether they're a religious person or not, that I pray that God gives them the comfort and the peace that they're looking for, and that He makes this journey smooth as possible for them.
I love that. Looks like we've got about 10 minutes left, and we have another question from Patty, which is great. Thank you, Patty. And it's actually another question I had on my list for the group. So open to the group. Can you share an experience that really moved you? Of course, we have to think about confidentiality. So if there is a patient story, just change the name, but something that maybe has really touched your heart. Does anyone have one ready? Let's see. I think I have Laura down first.
Yeah, oh gosh, it's a little hard to think of one because there's been so many. But we do have a program at our hospice called Creating Positive Memories, and it causes me to think about a particular gentleman. Even though it's probably been 12 years ago, I still think about him. This program allows us to, there's a fund, and it allows us to do things for patients or to support the patient in doing something that is really meaningful and special to them. And this particular gentleman that I had some animals that he had not been able to see because of his illness. And so we were able to have an ambulance service transport him to where his animals were so that he could spend time with them. And it was just amazing watching him connect with the animals that he had raised and loved for so many years. And just thinking about it now, it makes me want to cry. And like I said, it was a long time ago, but it was very special.
Yeah, there are so many that could definitely come to mind for me as well. Sherry, did you have one?
Yeah, there's something that happens to me every so often, usually with a dementia patient who has pretty much lost their verbal skills, but their family will have told me that going to church was really important to them and their faith is important to them. And so even if they can't talk to me, I'll sometimes read a familiar psalm or two and pray with them. And then I'll take out my iPhone and I'll play just some old-timey hymns, the Old Rugged Cross and Amazing Grace. And I mean, one woman in particular hadn't spoken in weeks, and she just started singing with me and knew every word. And it happens on a fairly regular basis. Someone that won't talk to me at all, they'll just close their eyes and start mouthing the words to the old songs. And I know that they're right back there in the church that was home for them. That was a place where they felt close to God, and it always touches my heart when that happens.
Yeah, that's a great one. Music can be so powerful. Marion, how about you?
Yeah, so I was actually thinking about a recent support group of mine. So I think I mentioned earlier, I facilitate one of our spouse and partner loss support groups. And I have always been so struck by what happens when somebody new attends group. It's always pretty intimidating. It's very vulnerable to share about your grief, let alone with a group of people you've never met for the first time. And every time it seems to happen where somebody will share their story, be vulnerable, and then you see the rest of the group say, us too, or me too. And just to see how it causes someone to soften, and the connection that happens and the healing that alone bring someone amidst their grief just like makes everything I do in my job worth it. I love it so much whenever I get the opportunity to see that happen.
There is like a click moment when people connect on something as emotional as grief. And then how about you, Sakina? Did you have a story?
Yes. I have one patient that I used to see. I seen this patient 3 times a week, and we would just talk and talk. And she went on about how she lived a great life, and she was ready, and she liked, her favorite drink was rum. She loved rum, and she made me promise that when she got to where she couldn't swallow anymore, that I would inform her family to dip 2 thets in rum and rub it on her tongue and her lips until she passed away. And so I came the day before she passed away, and she was bedridden at the time and not really responsive, but her nephew took the glass of rum, and the rum, and dipped it in the glass, the 2 that, and dipped it in a glass of rum, and rubbed it on her lips and her tongue. And she closed her mouth and smiled and said, "Yum." And then she passed the next day.
Oh, that one really made me smile. Yeah. That one actually made me think of a patient that I had who used to ask that I would come on a Friday at like 4 to see him, so that when I was off work at 5, him and I could have a Bud Light together. I would always say, like, I can't, my friend, I can't do that. But after he died, I did buy 1 can of Bud Light, and I split it with my husband, because just in honor of him, because he was a cool guy. I have been in the room a few times with actively dying patients who are talking to loved ones who have passed before. And to me, that's always really emotional and profound when, like, a spouse who died 11 years prior, they tell you that they're in the room with them. And, you know, you always say, I don't see them, but I know you do. But it is always so emotional and profound to be in that space. So we're wrapping up our hour here. I do want to say thank you to each and every one of my colleagues for your time and your efforts on this program. It's been my absolute pleasure working with each and every one of you on this and other exciting things that we have worked on. Our next episode will be at the end of May or early June, and it's going to highlight a couple of our wonderful physicians, Dr. John McGreevy and Dr. Annette Collier. And I will be asking them some common questions that I've heard and even had myself as a nurse over the years. So on behalf of Hospice of Northwest Ohio, thank you everyone who took the time out of their day to watch. It has been our pleasure to provide care in this community for the last 40 years. So if you guys just want to open up your mics, and we'll just all say thank you, and everybody take care.
Thank you.
Thanks.
Thank you.
Thank you.